I'd like to start by thanking the organisers for the opportunity to address this conference day. When I was asked to talk about the role of PPE, I thought, well, that's a bit barn door, really. Everybody knows about PPE, personal protective equipment, everybody knows what should be doing. Well, let's just be clear what it is we're talking about. We've got aprons and gloves, and I think they're the easy ones, because especially if there's a yuck factor involved, they go on automatically, don't they? But we also need to remember that personal protective equipment also includes masks and eye protection. And I'm going to touch on all of them today, just looking at what they're supposed to be used for and what really is the problem. But I want to start by saying I'm glad that there's 3 talks, one after the other, because really PPE is just part of standard precautions. And PPE alone won't work unless you've got hand hygiene, unless you've got good sharps disposal, unless you've got a clean environment, etc. So I don't want you to think about this as a compartmentalisation. It's part of a whole package, even though we're just giving it 15 minutes attention on its own. So the purpose of PPE is to protect the patient and also to protect the healthcare worker. And I think half the time we forget that in that protection, we're so busy thinking about protecting ourselves or the ritual of what happens in the ward that we forget about it's a two-way process. And one of the problems around whether or not to use PPE depends on people doing a risk assessment. And that's a risk assessment of, does this activity involve any blood or body fluid splashes, plus an awareness of what health and safety legislation tells us we must do in order to protect ourselves and our patients. And I think half the trouble is that the risk assessment fails to happen, that people are so ritualised into things that we don't actually think through, why am I wearing this, what is the problem? So let's start by looking at just the environment. And if you ever had any doubt about is the environment in which we work clean, then this is Clinell's picture about the high-touch surfaces that are nearly always contaminated within half an hour or so of cleaning them, because these are the things that people fiddle most with. And at the recent Infection Prevention Society conference, it was very clear that when it came to cleaning processes, cleaners are always worried about anything electrical. I think because they think they're going to sort of end up being sparked. So, whereas you might get surfaces cleaned, light switches and those sort of things are the least likely to be done. So we know we're working in a potentially contaminated environment, and we need to be careful of that. So aprons seem barn door. The evidence both in EPIC and in NICE, and one should just bear in mind that EPIC 3 will be out before Christmas, so that'll be your Christmas stocking reading, is very clear on when you wear an apron. You wear a disposable plastic apron if there's a risk that clothing may be exposed to blood, body fluids, excretions or secretions, and if there's a risk of a high amount of fluid, then you need a full body fluid repellent gown. Now that seems so simple. What could be, more different? If you're obviously a surgeon, you need the latter. If you're doing deliveries, you might consider doing the latter. But by and large, a plastic apron will do the job for most of us most of the time. So what's the problem? Well, first of all, we know that uniforms do become contaminated, so we need to be wearing an apron. And it was very interesting, the last talk here by Dr. Makin showed how even aprons get contaminated through hand washing. The problem is that aprons are put on for many at the beginning of the shift and not taken off until they go to coffee. And people forget that aprons should be put on for one activity alone and taken off at the end of that activity, and another one put on if required. There was also an issue that was very clear that where you store your aprons can also be a form of contamination, that if you actually leave aprons in the box stuffed on a radiator, then they collect dust, so they're contaminated before you actually start. So they need to be actually somewhere that are easily held, but they're also kept clean before use. The other problem is I sometimes think some nurses should also be working in the striptease department, because they actually need help on taking them off, because sometimes, as I say, they're taking them off because they're going to coffee, and there's this sort of rip and sort of, swish round the head as they actually go and put it into the thing because it's the end of the shift, they're going home or they're going off for coffee. What they need to be sure of is actually, if you've got put on an apron, it's because it's likely to have been contaminated, that it needs taking off carefully and folding and disposing of clinical waste. So it's not an easy thing. You know, people need constant reminders that, you know, these are put on for a reason and they need to be disposed of equally carefully. So that's aprons dealt with. Gloves provide a very good physical barrier to reduce contamination. And although we have a standard for what gloves in clinical practice need to meet, we cannot be assured about the integrity of gloves. And there is very good evidence that gloves will leak. And also, when you remove gloves, there is good evidence of people contaminating their hands, particularly with VRE, because again, it's not just the putting on, it's the taking off carefully and disposing carefully. Two things that come up to mind. I mean, gloves are sometimes a bit like aprons. A while ago, I had to take my son to an orthodontist and arrived to find the receptionist wearing a pair of gloves to answer the phone. And in the middle of it all, she went, yeah, okay, we can make that appointment next week. And then never took her gloves off and invited us into the room. You know, people wear gloves for their own protection without thinking about the purpose for the patient and the fact these are one activity only. Just to continue the dental theme, I once talked to a dentist who had a box of totally inappropriate gloves for the job. And I said to her, how do you manage to get those on? She said, it's dead easy, I blow in them first. And you sort of think, the message is not getting through as what we're wearing gloves for. So we need to be careful about we wearing the right sort of gloves for the right job and that we actually dispose them after that activity. And for many of those activities, we also need to wash our hands or decontaminate our hands after the removal of gloves because we know that they leak. So the problem is, you know, I've just gone ahead of myself slightly, that we know the focus is on protecting our own hands. We forget that they should be single-use items, and that is particularly when you're behind the curtains looking after one patient, you may be doing several things at once, that you need to remember to change them and that, you know, hands are washed afterwards. And here is really the most basic reminder, and this is actually in the Francis report. Many of you may have read this. This was by some evidence given by a patient's relative who said, my concern was about cross-contamination. I was concerned about it because the lady in the bed next to Mum had got MRSA. And I witnessed on more than one occasion them assisting this lady because she was unconscious, feeding her with gloves on. The lady across the bay wanted something doing with a catheter bag, and the care assistant, as she was, left the lady with MRSA, still with the gloves on, went across the ward and did what she had to do with the catheter bag and then returned to the patient with MRSA. I'm not medically trained, but to me, it didn't ring right that that could happen. It just seems common sense. If you're dealing with someone who has got something as serious as that wrong with them, you need to at least wash your hands. Surely that just reinforces what Louise has just been telling us. So there's gloves and aprons, and people, if you ask them what's PPE, will always say gloves and aprons, but they actually forget that masks are also a really important element. And people need to remember that they should be wearing masks where, having done the risk assessment, there is a risk of blood or body fluids splashing into the face. And also to be aware that wearing surgical masks provides no clinical experience. It almost seems it's like wearing a mask. It's a bit like having the stethoscope around the neck. It's part of the uniform, which actually has very little benefit. And if there is a serious respiratory condition, then you need a particulate filter mask. So two things to be said about the surgical masks. Surgical masks may be put on, but they actually need to be fitted over the nose rather than just slapped on and left. If you have an FFP3 respirator, you need to have that fit tested in order to make sure there's no leaks. Because if there's a leak, you're wasting your time wearing it. So we have a choice of masks. So what's the problem? Well, half the time they're not used when they are required. People prefer surgical masks over FP3 masks, and we have to bear in mind that if you look at the evidence over SARS, when we had the SARS epidemic in the East, the main problem was that people were using surgical masks and not disposing of them properly, because when they disposed of them, they didn't take them from the side, they were just taking them off and of course contaminating their hands at the same time, but they didn't provide sufficient protection as they were. So the FP3s need fit testing. And the other issue that we come across is the FP3, if you read the small print, it says these will last for 8 hours. Well, yes, they do, but that doesn't mean to say you put them in your pocket in the meantime. That they should be disposed of as you've finished. And you find that with people wandering around with masks in their pockets, as if it's some sort of, it's going to be their next tissue when they come out. And removal, again, masks need to have that swan removal, not just the, grab off the front and contaminate your hands. So masks are not particularly well done. Then when we look at eye protection, again, we need to think about splashing into the eye. And often, again, compliance is poor with mask wearing because people don't either see the issue for it or because the supplies that they're given they don't like. And if they don't like, they won't actually use it. Somebody was just reminding me the other day and saying, if you ever want to tell people why you should actually, wear masks and eye protection, think of the last time somebody sneezed in the car and just look at what happened to the front of the, if they're sitting in the front, what happened to your hand, wheel, etc. So, we often forget about that aerosol business. I just want to show you, these are just from an occupational health report of exposures at one trust. And in particular, I want to draw your attention to the yellow line, which is splashes to non-intact skin. And in fact, there's good evidence there, you see, that these go on. Obviously, needle stick are the real issue, and I'm not going to impinge on Ian's talk, which is going to happen shortly. But nevertheless, splashes are a significant aspect in trusts. And out of the last 3 months, looking at our last report, we had 120 staff who were implicated in a bloodborne risk exposure. Those included 63 nurses. They were the biggest group of all. 24 included mucous membrane exposure. 27 involved splashes. And in 14 occasions, it was clear that protective equipment that was required had not been worn. The conclusion in the report is, and I apologise for the length, but I think it's important to just stress, there is little change in compliance with the wearing of appropriate PPE. Numbers remain very similar to the last quarter. Staff are still failing to wear gloves for procedures such as venipuncture, and in some cases are removing gloves prior to disposal of used sharps. The splash incidents occurred during procedures such as cannulation, flushing of IV lines, bladder washout, suturing, abscess incision and deliveries, where the wearing of face protection is not a standard procedure, but would have prevented exposure of staff to blood and body fluids. It is evident that staff are not carrying out risk assessments prior to undertaking such procedures. So in summary, personal protective equipment is an important aspect of standard precautions. They're for the benefit of everyone, our workers and our patients, and yet we need to be mindful that they're not always appropriately used. But also, we need to be mindful that employers must provide supplies that are fit for purpose. And if you decide not to use what was available, it can affect your subsequent claim. So if people say, I had an eye exposure, and no, I wasn't wearing the glasses because I don't like them, well, you have no leg to stand on because the policy says to wear them and you chose not to do so. So we really need to fight to make sure that we have gloves that are suitable for the job that we need to do and other personal protective equipment that is suitable fit for purpose too. Just to finish on my yuck factor, I don't know if any of you saw this in Which recently, was asking how clean is your tablet? And it was a very small survey, but Which looked at 30 tablets, 30 phones, 30 keyboards, and you will see there that the worst tablet smartphone were far worse than the toilet seat. And in fact, one of the tablets had over 600 units. This was all of Staph aureus on them. and their point was made that if that had been a person working in the food industry, that level of contamination would have been required to have retraining. I just leave that thought with you. Thank you.